Of all of the laboratory values in the entire body, there is one that is most important, and that is the carbon dioxide, or the PaCO2. But why is it the most important, and what are we to think about it, and what do we do about it if CO2 rises? Let's check it out. As the Japanese would say, 𝗕𝗵𝗶𝗀𝗄. Carbon dioxide is the most important value in the whole body, and that's because it relates to ventilation. Keep in mind that there are several vital functions of life, including ventilation, oxygenation, circulation, and perfusion. But if ventilation doesn't happen, then all the other vital functions fall apart. And that's why the most important vital function is ventilation, and the most important key indicator of ventilation is carbon dioxide found in the arterial blood. All right, but let's take a look at carbon dioxide and learn just a little bit more about it. Carbon dioxide is not something that helps our body, but it is a natural byproduct of what's happening at the cellular level. So in other words, our body or our cells take in oxygen and then they put out CO2, just like we take in food and then we put out, well, you know. And so because of that, we have to watch carbon dioxide. It's not going to be helpful to the body. We only have one choice with it, and that is to get rid of it. Well, there are three ways that the body's going to get rid of it. Well, actually, there's only two. Another way, it actually just hides the CO2, so we'll talk about that. One of the ways that the body can get rid of carbon dioxide is through the urinary system. The carbon dioxide forming with other compounds to make other molecules permits the body to pee out carbon dioxide. The problem with urination is that it can't pee out very much of it, and so it's an inefficient way to get rid of carbon dioxide. The most efficient way and acute way to get rid of a climbing carbon dioxide because of poor ventilation in our body is to increase the ventilation. And that means just simply you and I breathing in and out. Breathing in and out is what can lower carbon dioxide quickly, and I mean right now. Within just a few seconds, we can lower our carbon dioxide because of how we breathe. But if our breathing is impaired or we're not ventilating as much as possible, then carbon dioxide can accumulate, and that can be deadly. But the number one way that the body gets rid of carbon dioxide is by ventilation. Now, I told you or hinted to you before that the body also has a third way of doing something with carbon dioxide, not getting rid of it, but keeping it in the body, but hiding it. And you probably know this already, but it's going to hide it in a special molecule called sodium bicarbonate. And I want you to look at this molecule for just a minute. Seriously, look at it very, very, very closely. Look at it. Can you see that inside the bicarbonate is a CO2? It's hiding the CO2 in its molecule. And then, of course, the CO2 can come out and it can go back in. Now, that's an ingenious way to prevent the body to have negative effects from the CO2, including acidity. The bicarb can just hide the CO2 from the body so it can't see it as CO2. The problem is that the bicarbonate formation, or that molecule, doesn't really have the ability to make a significant difference on ventilation or the CO2 level. And so it can do it to a degree, but it's also very slow. So if your CO2 goes up, your bicarbonate will start to form and it will try to hide the CO2, but it does so slowly that it doesn't really help us or prevent us from death or terminal problems. All right, now if you give the bicarbonate enough time, and we cover this in another video with bicarb, if you give it enough time, it can go up in a chronic situation and hide a lot more CO2, and this is what happens to chronic obstructive pulmonary disease who have CO2 retention. But in the short term, in an acute situation where somebody's not ventilating and the CO2 is rising, bicarbonate does try to come and be the hero, but it just can't. It's just not good enough. The only hero of the situation is ventilation. And so we can say that if the CO2 is rising, then the patient has a ventilation problem, and that's the thing that we should address first. Well, what is ventilation? Ventilation is just really the act of moving the air or the gas out here in the environment from here to the lungs. Inside the lungs, specifically to the distal portion of the lungs, in those tiny little sacs called the alveoli. The alveoli are little sacs that have a one-cell membrane that participate in gas exchange between the alveolar space and the artery. And that's how CO2 comes through that one cell thick alveolar capillary membrane into the alveoli and comes out. And of course, the other part of that is oxygen. But remember, we're following the CO2 at this point to determine how well somebody is ventilating. So the answer to decrease CO2 is literally to improve or increase the act of breathing in and out. Now, there's two parts of that function. We won't get too nerdy now, but one part is that the frequency at which you breathe in and out, and that's called your respiratory rate. But the other part is called the tidal volume, which is really the size of the breath. Together, those two things, if we multiply them together, we get ventilation. In fact, because respiratory rate is so many breaths per minute, we get minute ventilation. It's the minute ventilation, how many liters per minute are you moving in and out of your alveoli, that really is supporting your life and is blowing off that carbon dioxide. If somebody's CO2 is rising, therefore, our answer is to increase the minute ventilation. Now, that can be thought of in two different ways. It's one, to increase the size of their breath, and the other way is to increase the rate of their breath. Just to give you an idea, if somebody is spontaneously breathing, then we might sit them up and in the proper position so that they can take deeper breaths. That's going to increase the size of the breath. We might even coach them into taking deeper breaths. And then, of course, they will automatically start to breathe a little bit faster. If they're not breathing fast enough, we have to look at other processes. Do we have sedation on board? Is there something that would reduce that? Is there a neurological problem? Either way, the answer is to help them breathe mechanically. Now, let's take a look at some of the values on a blood gas if we're looking at CO2 to understand approximately what we should do to assist in the breathing process or to help them ventilate more. Now, this is not an exact science. This is a starting place for you to understand that when you look at a blood gas. Now, on a blood gas, if you look at the normal CO2, you'll see that the normal CO2 is between 35 and 45 millimeters of mercury. Sometimes, by the way, that's called a torr. Torr and millimeters of mercury, about the same. It's a pressure measurement. And so if the CO2 starts rising above 45, that's when we're starting to be concerned. Well, we are concerned at different levels. And so let me just give you some general guidelines of what you might think. If somebody's spontaneously breathing and their CO2 crosses the 45 mark and goes to 46, 47, 48, that's when we're thinking that we need to encourage deeper breathing. Now, we might do that by getting rid of the sedation and waking them up and slapping them around a little bit. Well, we won't slap them, but we'll at least say, hey, wake up, Mr. Johnson, and you need to take a deep breath. You'll see this tactic used especially after surgery. You'll have a nurse in the post-anesthesia recovery unit telling the patient to wake up and talking to them and take a breath, and that's a good way to do that. And so we can do that. Now, we can also use devices like incentive spirometers to encourage them to breathe, to wake up, put the mouthpiece in their mouth and take a deep breath and watch a little puck go up. That's also another way of increasing the size of their tidal volume. All right, now, but what if the CO2 starts climbing 49, 50, 51? Now we're a little bit more concerned and we're not totally confident the patient could do that on their own, so we'll employ probably something like a machine. Now, that machine may be a BiPAP machine, a non-invasive ventilator, or we might use other machines that just encourage deep breathing. Could be that the mask is placed on the patient's face and the machine automatically pushes in a breath. And there's all kinds of machines that do that. BiPAP is just one of them, also called non-invasive positive pressure breathing. And so we could use that. Now, if the CO2 keeps rising to something like 53, 54, 55, 56, that's when we start looking at the pH and understanding that there's evidence of absolute ventilatory failure. In other words, when the CO2 starts to hit 55, and I'm talking about a normal person, not a COPD patient here, that's when we realize we need serious help, and that's when we're going to use life support machine, also called a ventilator. And so we'll call that mechanical ventilatory support. We might have to put a tube in the patient, we probably will. We'll intubate the patient, and we'll put them on a ventilator, we'll take over. But those are the three main levels that we start addressing elevated CO2. Now, let me just address those respiratory therapists who are thinking, what if they're already on the ventilator and the CO2 is rising? Well, if the CO2 is rising, then that's much more easy to handle. Remember, you have two settings on the ventilator. You are controlling breath size with the setting of tidal volume, and you're controlling respiratory rate with the frequency setting. And so you can increase respiratory rate and you can also increase tidal volume. Of course, you can't give them bigger tidal volume than their body can tolerate, or you could cause a pneumothorax. But within those parameters, you can increase tidal volume and rate, and together you're increasing minute ventilation. And that's how we would control elevation of CO2 on a ventilator. Well, that's carbon dioxide. It is the most important laboratory value in the body to monitor and to address when it starts to rise up. Here at the end, though, I just want to mention something else that is commonly confused. When somebody has a ventilation problem, we can sometimes see that they have labored breathing. We might get a blood gas and see that their carbon dioxide is rising. One of the first things we have a tendency to do is to put them on oxygen. That is a correct thing to do, because think about this. If you're not ventilating very much, then you're not getting that oxygen molecule down into the alveoli. Now, I know ventilation is about getting the carbon dioxide out, and that's what we're monitoring. But remember, the other side of ventilation, the part that we would care about also, is that oxygen molecule is not getting in. Why? Because they're not breathing enough. If the oxygen molecule is not getting into the alveoli enough, then one thing that we can consider is that throughout the body they are being deprived of oxygen. The cells are being deprived of oxygen, and certainly the heart may be deprived of oxygen. And ultimately, if we did that long enough, we could have a cardiac arrest. So we want to give extra oxygen so that even though they're taking small breaths and they're not taking them frequently enough, at least in the breath that they are taking, it's full of oxygen. So what we're really doing is hedging our bets. However, and this is important, very often in the field, people will confuse the idea of giving oxygen with helping with ventilation. But the idea of CO2 going up and down has nothing to do with the amount of oxygen in the blood. I say nothing to do. There's triggers that make the patient breathe, especially a COPD patient. But you cannot solve a ventilation problem by giving a lot of oxygen. Remember, if they're not moving air in and out, or they're doing insufficiently, I could put them on a non-rebreather mask or a mask with tons of oxygen, and because they're not moving the air down into the lungs, then that oxygen's not going to help them a whole lot. What I'm trying to say is you can't fix a ventilation problem by putting them on more oxygen. We will, in the presence of a ventilation problem, put them on more oxygen to kind of hedge our bets, but that's not the primary fix. If the CO2 is rising, that means they're not breathing enough. Their breath is not big enough, or they're not breathing frequently enough, and we need to address those two issues. That's how we deal with a ventilation problem. Well, I'm Dennis Stanley with Respiratory Sensei. I hope this has been helpful. Remember, this is a new channel, and we're trying our best to help respiratory students, but also help those who are already in the field. And so we'll also talk about the other parameters in the arterial blood gas, including the pH and the PaO2 and the HCO3, or the sodium bicarbonate, and a few other implications. If the videos aren't out yet, then be sure to hit the notify button or the bell button so that you get notified whenever they do come out. So subscribe, and please share this with your friends to help the channel so that we can reach more people and produce more excellent content with some of our respiratory senseis. I'm Dennis Stanley with Respiratory Sensei, and as the Japanese would say, ja mata ne.